Welcome, everyone. We are incredibly excited to have everyone with us today. And I will make one quick editorial comment before I start with my formal comments, and that is the interventions and the research that you're going to be hearing about today, in my experience, are absolutely essential to implement and use if we ever hope to get and build a healthcare system that really does get it right and meet the needs of our patients, their families, and all of our clinicians and staff. So again, thank you for joining us, and thank you to everyone who has brought this day together. We'll begin by exploring how creative participatory design methods can invite patients and families to share their lived experiences and hopes for better care. These approaches help move us from consultation to true collaboration. We'll then shift to engagement and how it can enhance the design and effectiveness of CAHPS measurements tools to better reflect what matters most to patients today. We'll also look at how involving patients in survey design always leads to clearer language, more relevant questions, and more meaningful data. For the second half of today's meeting, we will examine how healthcare teams can move beyond tokenism and build sustained, supported partnerships with patients and families in quality improvement efforts. We are fortunate to also have speakers from the UK and Canada who will share their research and implementation strategies and how they use these to enhance co-design and co-production with patients and families. Finally, we'll reflect on the power of storytelling, how patient stories can deepen understanding, build empathy, and inspire meaningful change when used effectively. So with that, I am going to introduce our keynote speaker, Maura Cass. Maura is a seasoned design and innovation leader, having spent her career dedicated to bringing change and transformation to some of the most critical of human experiences within healthcare. As a current innovation consultant and former partner and head of Health North America at IDEO, one of the most prestigious design and innovation firms in the world, her expertise lies in leading multidisciplinary teams, conducting qualitative user research, and simplifying the complex to build actionable strategies that center on human needs. She's worked with many of the largest and best healthcare systems in the U.S. I can say I've had the good fortune to work with her on work at Mass General Brigham and at one of our community hospitals, Newton Wellesley, and it was incredible. She holds a bachelor's in anthropology from Dartmouth College and a master's in healthcare delivery science through the Tuck School of Business and the Geisel School of Medicine at Dartmouth. So welcome, Maura, and let's get started.
All right. Thank you, Susan. I trust that everyone can see my screen and can hear me. Great, thank you. Thank you for that introduction, Susan. I hope I'm not a little repetitive here as I introduce myself as well, and want to thank you for the opportunity to be able to share and connect with everyone here today. As Susan mentioned, by training, I think of myself as an anthropologist, which means I've always been drawn to understanding people's lived experiences and the context that shape them. And over the years, I've built a career as a design researcher and a human-centered designer. My work is really about bringing people's voices and perspectives into the process of shaping solutions, whether they be systems, tools, or new experiences, or even new assessments. I've been most excited to work at the intersection of human health, care, and connection, helping organizations, often clinicians, patients, families, caregivers, and communities work together to better understand what matters most to the people at the center of design. This is the perspective that I'll bring to today's conversation. Now, the goals of today's conference are clear: to consider the integral role of patients and families in the development and implementation of care experience assessments and quality improvement strategies. As a designer, I look for an opportunity to create change in everything I encounter. That is inherently what design is, the ability and process to create change for the better. The first step as a designer is to shape and define your design challenge. This will clearly articulate what it is we are trying to change, where we are focusing our efforts, and perhaps most importantly, who it is we are centering in the exploratory process. These are the ingredients to shape a how might we statement, which is a classic design opportunity framing. It lays the groundwork for a design-led effort. The how suggests that solutions are possible. The might suggests exploration, not a single answer. And the we reminds us that the process will be collaborative. So here's our design challenge for today. How might we engage patients and families in the creation and success of care assessments? This is an opportunity reframed to inspire creativity. Instead of stating the problem as a fixed obstacle, we're inviting usually a team to employ creative collaborative design methods in the pursuit of developing new solutions. And at the heart of this design challenge is a shared belief, as Susan just emphasized, or at least a shared hope that by engaging patients and families, we will better understand their experiences, particularly those that impact assessment success, so that we can then create and deliver a better product or service that meets our mutual goal of improving healthcare delivery and in turn, patient and family's health. So now we have our design challenge, and I hope you'll carry it with you for the rest of the day with curiosity, so that you might not only define the how, the methods and the tools, but also articulate the why, the reason and impactful outcomes that result in directly engaging patients and families. So now that we have that, let's dig a little bit more into what design is, in particular design thinking, the problem-solving methodology that I practice, and human-centered design, the mindset at the heart of design thinking, an approach that puts people, their needs, contexts, and lived experiences at the center of solutions. Again, for those that are less familiar, design thinking is a primary problem-solving methodology, and it differs quite greatly from traditional methods of improvement. All of these methods are quite valid and quite critical, but they're to be deployed against different types of problems. Design thinking and its research methods are particularly applicable when problems are complex and ambiguous, and when there is a culture and belief system in place that supports the creative pursuit of innovative new solutions. In other words, if the context and leadership in the place you work or the place you are trying to create a new solution is expecting a straightforward and predictable process and outcome, design will not be successful. And more often, participatory methods may also not be successful. When unfamiliar with the process or when more accustomed to traditional methods, this type of work can feel unsteady. In fact, this curvy looping image is often how we express the feeling of going through a design process. While the steps are actually fairly concrete and known, what you discover along the way often dictates where you go next. And you'll see this come to life in a case study I share shortly. While design typically follows the process of first gaining understanding from people, exploring ideas and concepts that seek to meet the needs you found in those people, testing those concepts, refining towards implementation, and so forth, we can never predict what we will learn along the way by involving people directly in the process. The research methods utilized during the design often are what help to create that curvy experience. First and foremost, the methods are holistic and compassionate. In design work, design research is not a phase. It's a continuous journey of discovery that always tries to understand as much about people's lives, their attitudes, needs, desires, as needed for any moment in a project life cycle. So at the beginning of a project, we might be exploring and broadly engaging people, but as we move forward with solutions, prototypes, things like that, we're re-engaging them with those prototypes to get their feedback and to involve them collaboratively. The methods are also mixed and design-led. We blend methods from anthropology, sociology, and psychology and more. And when creating prototypes or observing in context, running surveys, conducting interviews, we're generally pragmatic in how we choose our methods, but the combination of methods that are used are unique to each project. And finally, our methods are multidisciplinary and collaborative. The research approach for design believes that the best insights that drive solutions are grounded, surprising, and actionable. They come from weaving together multiple perspectives. So often the work is anchored by people with design research expertise, but inviting others into the work is really important. This includes other types of designers with different capabilities and skill sets, leaders and decision makers within an organization, and of course, patients, families, caregivers, and more. Now, one thing I do want to clarify is that while most methods of design research are collaborative, not all are true co-design, which requires shifting power and decision-making away from traditional leadership in organizations to the very people centered in the solution. This takes significant buy-in and cultural shifts in an organization, and this can be particularly difficult in healthcare, where there are often traditional definitions of expertise, leadership, and evidence-based adoption. So as you return to the design challenge we framed a little bit earlier, consider the context that you are working in, the capabilities that exist, but perhaps most importantly, the mindsets and culture that will need to exist to embrace new methods of research and ultimately allow them to be successful. So now let's walk through a case study to illuminate how some of the creative collaborative research methods that I just talked about can be applied and their power to create change by emboldening the voices and choices of patients and families, as well as inspiring change in the very caregivers and employees who will ultimately take on the work to deliver those new solutions. This is a case study within a case study. The full body of work was actually a series of projects that took place over a year within a hospital to really reimagine the overall patient and provider experience. The collective impact of those projects was meant to drive better patient outcomes through cultural and organizational change. And this particular project that we'll dive into focused on the day surgery department. The design challenge was this: how might we design a seamless and differentiated day surgery experience that leads to lasting patient impact? We partnered with an interdisciplinary team of those that help with the day surgery experience. So from front desk to charge nurse to anesthesiologist to a surgeon, we worked as one team of designers to engage patients and caregivers in the change and innovation process. As an overview, this is a broad look at the fast-paced project that was broken down into 3 phases that model the design process. And in each phase, we utilized collaborative research methods particular to what we were trying to do. So in the first phase, you see what's really about inspiration and understanding. So how do we really get to some of these core needs that we can design for in the day surgery experience? We're using methods like contextual interviews, field visits and shadowing, co-creation and co-design workshops. In phase 2, we're designing and prototyping. So this really iterative process of building solutions and bringing them back out into the field, testing them, getting feedback, continuing to iterate and go to the next prototype. And in the final phase, we're looking at refinement. So how do we actually start to take what we think is showing the direction of a solution we should start to implement and see how we might actually bring it to life in more realistic ways. To note, while oftentimes in the design process, we do utilize patient and family advisory councils in our work, working with hospitals and the like, what's important is that we also identify a range of individuals, profiles, et cetera, that we want to collaborate with as co-designers, patients and caregivers who have a range of experiences, a range of expectations, and a range of backgrounds. Sometimes these patients are not even patients in this hospital or in this care system, but we're looking for mindsets and needs that really might help us drive design. So in this way, we do our own recruiting in order to build a robust community of collaborators. And at places like IDEO, there is a robust operational system at hand to help recruit, identify, partner with community groups in order to involve this range of voices and people. But this is really to ensure that it's not only those that proactively engage that are directly heard. So let's dig into each phase. In phase 1, we started the work by going out into the world to empathize with those at the center of the design challenge. This included contextual interviewing and participatory design with over 20 patients and 20 hospital employees. And we even participated in things like immersion and observation. As one example, going through the surgical process ourselves as mock patients. Yes, we did arrive at the hospital at 4:45 a.m. No food, all of that. After going out and doing this research, we came back together as a team and we start to really talk about themes, pain points, to understand where we might focus our design for the highest impact. There were a lot of things that we learned, a lot of insights, a lot of opportunity for design across the day surgery experience. But we really started to gravitate towards this idea of designing for peace of mind. And we really identified the upfront experience of coming into surgery as where we thought the greatest opportunity would be. We identified 4 factors that were associated with peace of mind around setting expectations, managing control, providing information to the patient, and offering personalized care. Using those factors, we asked ourselves, what might we build? What might we try to create so that we can learn even more and try to meet those needs? So our first prototype, using the design skills of a design team, meaning we can build anything we like in really rough, raw, and easy ways at low investment. We built a kind of new before visit summary with these 4 insights as the base for it. And it was a digital tool that was sent to individuals through a personalized text message 24 to 48 hours before their scheduled surgery. Now, the point of the before visit summary, or BVS, was not to have something perfect. It was actually more about putting something out there and seeing how people react to it so that we could learn faster. We collected data in the form of website analytics so we could see the way our 18 prototype participants were actually using the BVS. And we saw really different behaviors. First, we saw that 77% of our participants went to the site, but what was interesting was how they used it differently. 27% of our participants went back multiple times. One person actually went back 5 times, and we saw one individual in particular pull up the pictures of where to park several moments before actually entering the hospital. So all of this different information, how do we make sense of it? Well, our big takeaway from that first prototype was that this kind of information and customer service is great, but the really big thing we learned was that the actual specific behaviors and ways that individuals defined peace of mind was what we needed to design for. So the question then became, how might we design for these different mindsets with one solid experience? Note that our takeaways weren't about the success of the BVS. It was not about how do we iterate the BVS? How do we make this better? The BVS was a tool to actually further collaborate and further identify where there was opportunity for design. So with those insights and another loop in that curvy design process, we used another creative design method called analogous research, and we got out of the hospital. We actually went to Boston's Logan Airport to study how JetBlue in particular created a very unique experience for very different types of customers. This type of analogous research is when we look outside the immediate context of a problem. We focus on a theme or understanding from our insights. So in this case, how do you deliver that seamless experience to different types of individuals? And we go and experience it in other domains to really inspire new thinking and use some of those parallels to innovate in a different area. Each of us checked in as different passenger types, and from first arrival to final boarding, we saw with fresh eyes how this high-touch customer service organization provided customer value in a complex setting. But perhaps most effectively, the entire day surgery team sat down with the entire JetBlue team. So from customer service representatives to pilots, we saw the front desk person to the charge nurse to a surgeon discuss how they worked as a team to deliver these unique experiences. And what we realized, and what was really uniting on that mindset and cultural front, was that in order to deliver an experience like this, unique experience for different mindsets, you had to have a united team on the other end, and that was no different in healthcare. So time for prototype number 2. Meet Care Modes. Care Modes was a tool that we built to empower the hospital care team to help tailor their approach and interaction with patients based on patients' unique needs beyond simply their clinical requirements. A care mode was determined based on 2 factors that emerged from our research: a patient's degree of self-advocacy in a medical setting and their confidence that surgery was the best solution to their issue. And from there, 4 mindsets emerged. In order to prototype this, we worked with the entire day surgery team to develop specific tools that notified and empowered the care team to tailor their approach and interaction with patients based on the patient's care mode. We then worked with 20 surgical patients to first identify their care mode or care mindset, and then empower the care providers to react and meet their needs throughout their day. Historically, care providers have been trained to deliver consistent care above all else for quality outcomes. However, care modes powerfully acknowledge that patients respond differently to different types of care, different types of communication, different types of personal interaction. And these care modes empower the team, from surgeons to nurses to anesthesiologists, with the tools and the upfront knowledge to interact with and provide care for patients so that the patients, and often their families and caregivers, also feel comfortable. Based on this prototype success with patients and impact on the staff culture, we then worked to incorporate care modes into EPIC, the hospital's electronic medical record. Now, we know the importance of being patient-centered has been central to the healthcare conversation over the past 30 years and more. But new explorations such as this case study reveal that there's far more potential for innovation and improvement when both the patient and family experience is also considered in tandem with the provider and employee experience. Because we know that when we invite them all into the process using creative and collaborative research methods, we will have greater success in actually bringing change to life. Now, before concluding, I want to reflect on a few principles that I hope will be key considerations for our design challenge of the day. There are many lessons of this work, and I trust that throughout the rest of the day, others will be able to much better contextualize specific methods that feel immediately actionable. However, I do want to leave you all with a few principles that should be considered as you seek to engage patients and families more broadly. Ultimately, it is more than just the methods that enable new outcomes. So principle 1, place value on the skills required to do this work and the partners that enable it. What I've learned is that collaborative research methods, and in particular design approaches, require new skill sets, those that today may not be recognized or even respected in traditional healthcare environments. Hiring in such skills may be less likely or difficult than finding partners that have this expertise. And these partners may also be unexpected. Local community groups, for example, who have relationships and access to more patients and community voices. In these instances, we must compensate and partner with them as we would with any other vendor, medical group, or otherwise, in order to ensure their work and value are clear. Principle 2, develop the mindsets, not just the methods, especially in leadership. I hope I've emphasized this a few times, but working in this new way with new methods require new mindsets from top to bottom. In design in particular, we must embrace a loss of control, the unknown, and we have to fall in love with the problem, not the solution. We have to listen and trust new voices. We have to be willing to move in unexpected directions and embrace solutions that may be unorthodox. We have to celebrate failure as part of the process, and we have to build a culture of continuous feedback. These are often new mindsets in traditional healthcare organizations, and they require nurturing. Principle 3, own your sphere of influence and reinforce the boundaries. When working with patients, community members, families, and more, there can be a fear of being unable to address their needs, and the repercussions of engaging them and not meeting their expectations can feel paralyzing. But the best way to address this is to be extremely clear about the bounds of your work, the bounds of your influence, and the change you can truly affect, and communicate that over and over and over again to those you are working closely with. And finally, principle 4, build the systems and structures that enable meaningful relationships. Trust breaks down when you do not follow through. And if you are going to work more closely with patients and families, you must make sure that there are organizational structures to engage them, not just the first time, but continuously and moving forward. This ensures mutual exchange, an ability to follow up with them, and an ability to compensate them for their contributions. Do not start this work if you cannot ensure that you can build and maintain trust. And these are the 4 principles that have come out of lots of my work around how to create those meaningful relationships. Design for back and forth interaction, shared value, continuous engagement over time, and emotional exchange. This is an important way to ensure that a true relationship has been created. That's it from me. I hope that I shared today helped to set the tone for meaningful and inspiring conversations. I look forward to the Q&A that follows, and I look forward to connecting with many of you today and onwards. Thank you.
Maura, I think we're now going to post a polling question, and so we'd love for people to answer this. Okay. Well, this is really helpful because based on my reading of the results, only about 15% of our audience has done this frequently, almost 40% occasionally, and 46% are really interested, and nobody's not interested. So that's great. And I think with this knowledge, I think everyone who's here today is really going to benefit from the rest of our presentations in addition to Maura's. One quick thing I just want to say is that Maura's slides are not posted on the website, but I think if you're interested in more information, I would suggest that you reach out to her. And so I'm going to look and see what other questions we have. And I actually have a question while I'm looking. One of the things that I found in this work that can sometimes be challenging for healthcare organizations is how to actually compensate people that are partnering with us and working with us, either in one-time events or in ongoing relationships to redesign care. Can you say a little bit about the different methodologies or the different ways that you've seen organizations manage that?
Yes, of course. There, in terms of value, there is a range of ways to express that. I think the best way is to, like I said in one of those principles, ensure that when you look at the policies in your organization for how you might engage other partners or vendors, the ways that you might compensate them, you think about consistency in that, in the way that you might also compensate patients and families. There are obviously standards around sort of hourly rates and things like that, but being very upfront actually with that level of compensation, the why behind that, because their voice, their perspective, their experiences are incredibly valuable and consistent with where we place value in other places, is really important. But there is, like I mentioned, a whole operational system to ensure that compensation can be provided in a consistent, formal and appropriate way. And it's often a conversation too. I know from my experience at IDEO, we certainly had sort of standard different rates that were appropriate for different types of individuals, but it's a question also about what is most valuable to them. So is it, a gift card? Is it actually some other type of compensation? Are there further relationships or ways to involve them that's also going to create that level of mutual exchange? So it's also just not about assuming, but having that conversation also about what is going to provide that level of value with those individuals or teams or new partners.
That's great. I mean, one thing we often will talk to people about, would they rather be paid with some sort of cash compensation, which we do by sort of enrolling them in a per diem employee system that we have, or, we find that oftentimes people want gift cards to local grocery stores or Target or things like that. But we do have another question that I think is particularly important, and it always jumps out at me because it's something I've struggled with, and that is fall in love with the problem, not the solution. So can you say a little bit more about that?
Yeah, this is a big one and a big part of the kind of core culture and belief system in the design process. It's why a design team is incredibly interdisciplinary. It's why the process actually creates the conditions where not a single voice is the decision maker. And that's because what you're trying to do as a designer, as someone who's embracing participatory methods, is remove yourself, your context, your opinions, and follow the process that actually says, what did we learn? What did we hear? What are you telling us? And what does that mean for sort of the truths or insights that are going to be what we continuously return to say, are we actually creating something that is delivering on the needs, on the voices of what we've heard along the way? And it's also why when we do research and design research, it is not an upfront process. It is not saying, here's what we know, and so we're done. Here are the insights. Now go make something and deliver it. It's actually about, hey, we talked to you at a high level at this moment in time. Now we built this thing. What do you think about that? Now we're trying this out again. What do you think about that? And the participation of those voices of patients and family actually helps to make sure that if there are designers that are making choices in participatory design versus co-design, where the power, the decision-making might actually shift, it's a checks and balances system that says, actually you were pushing an idea, but we're going to tell you now that that concept doesn't actually work. So as designers, it's one of your most important things to embrace that mindset of the fun, the engagement, the excitement of doing this work is about constantly asking yourself, are we solving the right problem? Not whether I built this beautiful thing that I'm going to make sure is successful. So that is critical in the work.
Yeah, I found I have to have a lot of humility and curiosity. We have another really critical question, and that is, how have you inspired health system leadership to support what is still an unusual approach to program improvement and design?
Great question. This comes with a bit of a...
told me to...
Somebody is not on mute. Go ahead.
I think they're muted now. This, I think I sort of maybe didn't say this as explicitly as I could have in my presentation. One core belief that I have is that work like this actually cannot begin unless you are certain that there are leaders and influential people who are bought in and share the mindsets. So sometimes there is pre-work to actually doing work using these methods that engages individuals, creates buy-in, and ensures that foundation is there. So oftentimes in my experience, work begins once there actually is a dedicated leader of influence who believes wholeheartedly in this type of work and type of approach and can evangelize that across the system. It's incredibly difficult to do the reverse, where you do the work and then try to convince a group of leaders that are sitting in traditional ways of thinking and honestly in traditional decision-making sort of power dynamics to be convinced of the value of this work. And so that is in those principles that I listed, which is to say leadership must have the mindset for this work to be successful. And ask those questions, dig into that before really beginning this work, because if you don't, then you start to actually affect that final principle, which is really holding up and honoring those relationships with patients and families and making sure that you are continuously building trust, because you do not want that trust to break down. It will be difficult to come back from that.
That's great. That's really helpful. Another question that sort of follows on to what you just said is, in your experience, who are the people in the different healthcare organizations that, I love this term, sort of act as the organizational Sherpa to make sure the project is successful? Where do these projects typically land for executive sponsorship?
It can be very varied depending on the structure of the organization. You find that within the traditional structures, when you're looking at places within an organization where you're seeing similar mindsets that already exist, you might be in a marketing department. If there's kind of consumer insights, things like that, there's some like-minded folks there. Patient experience, obviously. And then if you're looking at kind of leadership level, whether it's a CEO or if there's a chief experience officer, things like that, where those folks from a leadership perspective have said, I have many pillars, safety, quality, effectiveness, all of these things in healthcare, but I'm putting experience up there as well. And I believe that that's actually going to be a differentiator, not just in terms of us, growing and increasing volume of our patients, but actually in the quality of care that is delivered and therefore our outcomes. So looking for some of those things, I think can be very critical in terms of where there might be like-minded folks. But I will say one other thing, which is that in terms of more of the evangelists, those that are going to help really embrace this way of working, that can actually come from all over. And when we build a team to work on a project like this, to engage in participatory methods, like in this case study where I talked about that interdisciplinary team, we actually go through a pretty detailed process of looking at mindsets about people that have deep relationships within an organization. And that doesn't have to be the person with the most power, right? In many cases, actually, it's folks that have just have those values of creating deep relationships and are trusted across the organization. And so it might be someone in food services, it might be someone in non-traditional areas in the hospital you might first go to, but involving them in the work, building belief actually across different levels within an organization is often how this spreads and takes hold as well.
Great. Thank you. I think that you're prescient, Maura, because I think that leads to our final question, and that is, say a little bit about how different organizations identify the patients or family members, I think depending on the nature of the problem, to involve in the design work.
Yeah, this is a big one. And I also alluded to this on one of my slides when I talked about, patient and family advisory councils and committees. Some of the more traditional ways that hospital systems and healthcare organizations currently have structures in place to engage patient and families, those are great and outstanding. And there are some also, exemplary examples of how those groups came together and how they're utilized. But what we always do at the beginning of a project, and always have room for improvement around this, is we're looking at really kind of a bell curve and a range of experiences around the design challenge that we're looking at, and saying, how do we make sure that we hear from a range of these experiences? And you'll notice in the case study that I gave, in design research, you're not actually looking for a large number of participants in each of your cycles. As you move along, you're acquiring a large number of individuals, but you're actually going pretty deep with a smaller number of individuals. So you're hitting a range of individuals in smaller quantities, but then repeating that very consistently in the iterative process. But you need to identify those perspectives, those different experiences, the range of individuals that you're looking to engage with. And then you have to have the systems and structures in place to involve them. And like I said, patient and family councils often, not always, are folks that are already engaged, that have stories and experiences that have activated them. In the 2x2 for care modes, we talk about kind of agency in healthcare, those that have agency, that believe their voice is going to be listened to. Some of these profiles are very consistent in those that are engaged in those councils. And so we have to then be creative and say, there's a lot of other people, a lot of other experiences that should inform how we think about designing a solution. What are ways that we gather them? At a place like IDEO, there's a lot of operational systems in place to do that, a lot of different methods for recruiting, from posting on Facebook to looking at community partners, to involving other kind of organizations that actually have, communities built up that we can re-engage. But like I mentioned in that principle, it also might be sort of saying, in our community, where are there other places that people are gathering that might have perspectives we're not involving, and how do we become trusted with those individuals so that we might say, can we work with you to, connect with voices that we currently aren't involving? And so that's where you need to be creative too, to say, like, where are these individuals that we're not hearing from, and what is the way that we meet them where they are to engage them?
That's great. One thing I'll say, we're out of time, but one just quick addition to what you just said is, I know some of the patient experience vendors have platforms where when people complete a survey, they ask them if they'd like to help us improve. And if they say yes, they go into a database, and you can use that database to identify people that have the characteristics that you might need for a specific project you're working on, because you can't cover everything with PFAC members. So that's something I would encourage people to look into. So I think we're done. Thank you so much. You've given us a ton to think about. And I'm going to turn this over now to Dale Schaller for the next section of our summit.
Great. Thank you, Susan. And Maura, that was terrific. What a beautiful, inspiring way to start the meeting. You've given us, as Susan said, just so much to think about. Very informative and engaging.